So next is Post-Laparoscopic Cholecystectomy Bile V3. You have performed an elective straightforward laparoscopic cholecystectomy on a 56-year-old man. He developed abdominal pain in the same afternoon and was kept in the hospital overnight. In the morning, he is pyrexial and still in pain. How will you manage him? This is an unexpected outcome after straightforward lap cholecystectomy, so I would admit him and will sustain him with oxygen, fluid, opioid analgesia, send all his bloods, including septic 6, and then blood culture, and then we will do an ultrasound scan of the abdomen as the initial investigation. The ultrasound shows the fluid collection in the right subphrenic space and you suspect a bile leak. How will you manage the patient? It is not unusual to see some fluid in the Mersenne point at that state of the surgery, at that space of the surgery after laparoscopy, but if there has been significant intraoperative irrigation, that is often difficult to completely drain. The important consideration here is to determine the size of the fluid collection, the nature of the collection, and the possible presence of infection. If a localized collection is identified, the next step in the management would be to obtain a percutaneous drainage of the collection under radiological guidance. So this will help to obtain the fluid to determine the nature, obtain a specimen for culture and century, and place a drainage catheter for monitoring of the drainage trend. Most patients after the drainage catheter for monitoring of drainage trend improve significantly, especially clinically. If the fluid drained is bile, this could be from residual bile spill during the surgery, number 1, bile leak from the gallbladder bed through the ducts of Luschka, or it could be a leak from the cystic duct stump from misplaced clip, or more sinisterly, it could be an iatrogenic bile duct injury. So ultrasound guided drainage have 3 importance: nature of the fluid, culture sensitivity, and catheter. And then if the fluid drain is bile, this could be from the residual bile which was not drained. It could be from the bile leak from the cystic stump of or it could be leak from the ducts of Luschka, and it could be from the iatrogenic bile duct injury. And if residual bile spillage and bile leak from the gallbladder bed, the drainage should be of small volume. If the drain is pouring out high volume persistent drainage, then we should request an MRCP. The MRCP suggests a possible partial disruption of the extrahepatic biliary tree with an evidence of pre-biliary fluid collection. How will you manage the patient? So the appropriate next step will be to do an ERCP to properly determine the extent of the injury and the potential for endoscopic stenting as a therapeutic option. If RCP shows a leak through the cystic duct stump, this is best addressed by ERCP and the stent 4 to 6 weeks, and then re-image, cross-sectional image. If it's negative, then stent can be removed. If ERCP shows an injury to the main extrahepatic biliary duct system, this is usually better addressed by surgical repair or hepatic duodenostomy, as ERCP stenting for wall disruption tend to result in the biliary stricture in the longer term. And the choice of primary repair without diverting to tube or stent, or the alternative hepatic duodenostomy with a Roux-en-Y loop, depends on the extent of the bile duct injury and the potential for long-term stitching, as well as the timing of the surgery after injury. Immediate surgery within a week repairs tend to be preferred as a conferring best long-term outcomes. What are the possible complications following hepatic duodenostomy? So cholangitis, anosmotic disruption, and reflux congiitis, and stricture in the longer run. So if you talk about the CBD injuries, there are 2 classifications. One is I remembered with the name of Strasbourg. So Strasbourg A is bile leak from the cystic duct or cystic stump. Type B is occlusion of the right hepatic aberrant, and type C is transaction of the aberrant right hepatic, and Strasbourg D is main duct injury, and then E is main duct at the hilar level injury. And then is the bismuth. Bismuth is 1, 2, 3, 4, 5. Bismuth 1 is stump more than 2 centimeters, stump 2 less than 2 centimeters, stump 3 confluence intact but tied, and 4 confluence impaired, and 5 is aberrant rectal duct and the common hepatic duct injury. Thank you.